Hey everyone, we are going to start with the new important vascular disorders of the retina. We have discussed about the hypertensive retinopathy. Now we are going to discuss about retinal vein occlusive disease. Now the retinal vein occlusions are more common than the artery occlusions. So we have to understand that the retinal vein occlusions are considered to be as a more common as compared to the artery occlusions, and these are the ones which affects the elderly patients in the 6th or 7th decades of life. Now we have to discuss about the pathogenesis. Now retinal venous occlusive disease is due to the first we have to understand is due to the thrombus formation. Due to the thrombus formation, it leads to this disease which causes the occlusion of the vein. But there are some important predisposing factors. Now, what are the various predisposing factors are there which is causing this disease is age. Now, this predisposing factor we will write down. The first important predisposing factor is the age. Now, age is the most important factor which affects all the three components of the virtuous triad. Most cases occurs above 50 years of the age. Second is very important, which says that hypertension and diabetes mellitus. Now, hypertension and diabetes mellitus are very common predisposing factors for this diseases. Now, next is the third important is the hyperviscosity of the blood. We have the hyperviscosity of the blood. Now, the hyperviscosity of the blood is another predisposing factor for the retinal vein occlusions. Now, hyperviscosity of the blood can be seen in the polycythemia, hyperlipidemia, macroglobulinemia, leukemias, multiple myeloma, cryoglobulinias, hyperhomocysteinemias. In the hyperhomocysteinemias, it's a very common. Next is known as the perifibrillatus retinae, which can be central or peripheral, associated with the syphilis, SLE, Behçet's disease, Wegener's granulomatosis. Now the fifth, now this is a very important factor or the important risk factor, which is the raised intraocular pressure. The raised intraocular pressure, now sometimes what happens, the central retinal vein occlusion is more common in the patients who are suffering from the primary open angle glaucoma. Now increased raised IOP pressure associated with the primary open angle glaucoma, so we have to diagnose this condition in the patient suffering from the retinal vein occlusions. Next is other various conditions like patients on the OCPs in the younger females and the HRTs in the elderly females are common risk factors. Smoking. Now, smoking also predisposes to the venous occlusive diseases. Local causes are there like orbital cellulitis, orbital tumors, facial erysipelas, and cavernous sinus thrombosis. So these are this. Now let's start with the pathogenesis. Now what does the pathogenesis state? The pathogenesis states that there is a pressure on the vein by the atherosclerotic retinal artery. Let's say it's a vein. Now there is a pressure on this vein by an artery which is atherosclerotic retinal artery. So there is atherosclerosis. Let's make atherosclerosis. Now there is a atherosclerotic artery, and this atherosclerotic artery is putting pressure on this retinal vein. Now pressure on the vein by the atherosclerotic artery. So let's start with this. Now what happens? There is a pressure on the vein by the atherosclerotic retinal artery, where they share a common adventitious sheath just behind the lamella cribrosa and at the AV crossing. So it says that these are usually seen at the AV crossing, like these are usually seen at the lamella cribrosa and at the AV crossing, where both the vein and the artery shares the common adventitia. Secondary induces thrombosis in the lumen of the vein in the predisposing patients, like predisposing factors, so it causes the thrombosis in the lumen of the vein. According to the virtuous triad, the factors which cause thrombus formation are slowing of the bloodstream, we have changing in the vessel wall which is damaged to endothelium, and changes in the blood. That is the stasis, hyperviscosity. This condition leads to changes in the blood. Let's start with the classification of that. Classification to the retinal vein occlusion. Now we have the classification of the retinal vein occlusions. Now the classification we have to understand, like we have the classification divides it into two. Now the classification states we have the central retinal vein occlusions and we have the branch retinal vein occlusions. We have the central retinal vein occlusions and we have the branch retinal vein occlusions. Now the central retinal vein occlusions, it says that it can be impending type of the central retinal vein occlusion, and main ones are the non-ischemic. One is called as a non-ischemic type of the central retinal vein occlusions, which is also known as a venous stasis retinopathy, and second is known as the ischemic type of the central retinal vein occlusion. तो हमें यही रिमेंबर रखना है कि जो हमारा रेटिनल वेन occlusion है उसमें एक हमारा सेंट्रल रेटिनल वेन occlusion होता है जिसमें वी हैव नॉन इस्चेमिक टाइप एंड वी हैव इस्चेमिक टाइप एंड देयर आर डिफरेंस जो दोनों में रहते हैं, एंड वी हैव द ब्रांच रेटिनल वेन occlusion विच डिपेंड्स कि किस पार्ट की रेटिनल वेन हमारी अफेक्टेड है, occluded है, जिसके बेसिस पे ब्रांच रेटिनल वेन occlusion कैन बी hemiretinal vein occlusion, it can be hemiretinal vein occlusion, it can be quadriretinal vein occlusion, it can be a quadriretinal vein occlusion, or it can even be a small branch occlusion. It can either be a small branch occlusion. So this is a classification of the retinal vein occlusion. Now we have the main topic, which is known as the central retinal vein occlusion. So let's have a discussion on the central retinal vein occlusion. Now what is the central retinal vein occlusion? So we have discussed it can be impending type of the central retinal vein occlusion, but main are non-ischemic type of the CRVO, and we have the ischemic type of the CRVO. Let's discuss something about the impending type. Impending means partial. This is a partial occlusion which is more common in the younger patients as compared to the adults, and there's a mild, the basic important symptom. Now you have to understand about the symptoms and the sign. So in the impending type, there is mild blurring of the vision which worsens on waking and improves over the day, and the signs includes mild retinal venous dilatation and associated with few scattered flame-shaped hemorrhages and the mild macular edema. So this is just about the retinal vein occlusion, which is impending type. OCT reveals the mild macular edema, that is optical coherence tomography. Now we have FFA, that is fluorescent fundus angiography, shows the increased retinal circulation time, and FAF, that is fundus autofluorescence, may show a phone-like perivenular appearance. Now treatment is empirical and aimed at preventing the prognosis, like we can correct the predisposing factors, avoid the dehydration of the patients, lowering the IOP by the topical beta blockers or the topical and oral carbonic anhydrase inhibitors, antiplatelets agents and other anticoagulants measures may be tried. Now this was about something about the important part, that is impending time, but basic is the non-ischemic. Now non-ischemic and ischemic, we have to know the difference. Now difference is that non-ischemic CROV, which is also known as a venous status retinopathy, is a most common clinical variety. Now between the ischemic and non-ischemic, we have to understand that non-ischemic is a most common variety which includes 75%. Now the important clinical features are like vision. So unilateral mild to moderate blurring of vision of sudden onset is the presenting symptom. So there is mild to moderate blurring of vision, and RAPT, that is relative afferent pupillary defect, is absent, which is a very important differentiating feature from the ischemic one, is absent or very mild. Fundus examination in the early cases, and we have some late cases. Now we have some early cases, and what is the thing which is going to occur in the late cases are there. Now late cases is same like we have in the one. Let's start with that. So in the early cases shows mild venous congestion and tortuosity, superficial flame-shaped hemorrhages, which is more in the peripheral than the posterior retina, mild papilledema and mild or no macular edema may be present. Now we have to other basic late changes includes again same like we have the marked sheathing around the veins, we have the collaterals are seen around the disc, okay, we have celoretinal collaterals which is present. Now let's start with the ischemic type of the CROV. Now the ischemic type is that first thing, like we have said that about 30% of cases of the non-ischemic can convert into the ischemic type, and the thing about ischemic is that it is dangerous, it causes the marked visual loss and it's sudden, and there is RAPT present. Now ischemic CROV is also known as a hemorrhagic retinopathy, refers to acute or the sudden complete occlusion of the retinal vein. It's a sudden complete occlusion of the retinal vein. It usually occurs in the elderly people with the cardiovascular diseases, in the patients who are suffering from the cardiovascular diseases. Now the difference between this and this is that here there was mild to moderate blurring of the vision, but here the vision loss is marked and sudden, and there is RAPT is almost present. Now the funding examination. Now the funding examination shows retinal vein shows massive engorgement, congestion, tortuosity, and retinal hemorrhages are massive. Now in this retinal hemorrhages are a lot massive, almost fundus is full of hemorrhages, giving a splash tomato appearance. So it's very important, like splash tomato appearance is going to come in this ischemic CROV. We have cotton wool spots, that is the infarcts numerous 6 to 10, and this shows edema and hyperemia. We have macular areas full of hemorrhages and swirly edematous. Breakthrough vitreous hemorrhages may be seen in some cases. Late cases in the fundus show marks sheeting around the vessels. We have the collaterals are seen around the disc, and we have neovascularization, marked feature. So this was not seen in the non-ischemic one. We have neovascularization which can be seen around the disc. So neovascularization, we have disc, and we have the neovascularization which is present in the periphery. Macula shows marked pigmentary changes. So there are pigmentary changes, and there can be this chronic cystoid edema. There can be the chronic cystoid edema. There can be chronic cystoid edema. There is the presence of the chronic cystoid edema. Now pathognomic features for ischemic CRVO differentiated from non-ischemic CRVO is very important. So I'm sorry that it's unclear, but let's see what are they. They say that there is presence of RAPT. In the ischemic type, visual field defects are more prominent in this type. Visual field defects are more prominent in the ischemic type. They are more prominent in the ischemic type. And next important difference is that there is reduced amplitude of the B wave of the electroretinogram. Now the complications. So there are only two complications. One is called as a rubeosus iridis, that is a neovascularization of the iris, and the neovascular glaucoma. Very important. It's a neovascular glaucoma. It's a question like in which type you see a neovascular glaucoma, which is also known as a 90 days glaucoma, which is basically occurrence 20% of cases within the 3 months. That is the rubeosus iridis and the neovascular glaucoma. So neovascular glaucoma, 90 days glaucoma, and we have the rubeosus iridis. These are the complication. Rubeosus iridis, which is the neovascularization of the iris, and we have the neovascular glaucoma. We can have some vitreous hemorrhages and proliferative retinopathy occur in few cases. Let's have some discussion on the branch retinal vein occlusions. It says that it's more common than central retinal vein occlusions. So in this retinal vein occlusions, we know that they're more common than the retinal artery occlusions, and in that also we have non-ischemic type, which is more common, and between them we have the branch retinal vein occlusions to be as more common than the central retinal vein occlusions. We can have the hemispheric occlusions, which is due to the occlusion in the main branch at the disc. We can have the quadrantic type of the occlusion, which occurs at the level of AV crossing, which is commonest in the supratemporal branch of the retinal vein occlusions, and we have the small branch occlusions either as the macular branch occlusions or as the peripheral branch occlusions. Features. Now vision is affected only when the macular area is involved. Retinal edema and hemorrhages are limited to the area drained by the affected vein. Secondary glaucoma rarely occurs rarely in these cases. We have this chronic macular edema, and the neovascularization may occur as a complication of PRVO in about 1/3 cases. Let's have a discussion on the management of the retinal vein occlusion. So what are the various management that we are going to do in the retinal vein occlusion? Let's start. Now first is the clinical evaluation. We have to go with the clinical evaluations and the investigations. In the clinical evaluations, jab bhi likhna hai, we have to go with the ocular examinations and investigations, in which the first important is the ocular examination should include visual acuity at the presentation and at every follow-up. Is a useful guide for the interventions required. IOP should be recorded, and associated primary open angle glaucoma should be ruled out because it's one of the major risk factor for the retinal vein occlusions. Undilated slit lamp examination to detect the neovascularization of the iris. If there is neovascularization of the iris, that is rubeosus iridis, like if there is a complication or not. We can have the gonioscopy to rule out the neovascularization of the angle of the anterior chamber. We do gonioscopy for that. We go with the fundus examination with the direct and indirect ophthalmoscopy, and with the 90D slit lamp examination. So the slit lamp examination with the 90D lens, we can go with that. And we have the other ocular investigations, like we can have the Goldman perimetry for measuring the perimetry is there, that we can go with the measuring of the visual field, or what is the visual field is there. Okay, next we can go with the electroretinogram. It's a very important in differentiating between the ischemic and non-ischemic type, because in the ischemic type the visual field effects are more. Okay, there is decrease, we have discussed now, there is decrease in a wave that was known as, which type of the wave was there? Decrease in the B wave that occurs, that is going to differentiate from that. On the we have the B wave of the on the electroretinogram, that is electroretinogram. Now we have the next is fundus autofluorescence. In both non-ischemic and ischemic CRVO shows typical phone like perivenular hypoautofluorescence due to the masking of the background signal by edema. We can go with the fundus fluorescence angiography should be carried out. Okay, we have the FFA, that is a fundus fluorescence angiography to assess the state of the retinal perfusion after resolution of the retinal hemorrhages. We can go with the optical coherence tomography. Next is, in the ischemic CROV, we usually have the areas of the capillary non-perfusions of about more than 10 disc areas. In non-ischemic CROV, FF shows delayed AV transit time. Now we have the OCT. OCT is useful for evaluation of the macular edema, subretinal fluid accumulation, or the development of the epiretinal membrane. Now, systemic examination is important. Why? Because which may be needed for looked for hypertension, hypercoagulability, hypercoagulative conditions, like we have various hyperviscosity of the blood conditions in the multiple myelomas and the polycythemias. We have to rule out that because they are the important risk factors. We can have homocystinosis, especially in the young patients. Next, differential diagnosis is simple. Like diabetic retinopathy is generally bilateral. It's usually a unilateral condition. And there is also one thing which is known as the ocular ischemic syndrome due to the carotid occlusive disease. Has only dilated veins without the tortuosity, that is the engorgement. In CRVO, tortuosity is also seen, and retinal hemorrhages are typically seen in the mid-periphery. Next, we have the differential diagnosis. After that, treatment. What is a treatment? Now, treatment includes we can go with the, firstly, we can have the treatment of the systemic and ocular associations, like you have to treat the hypertension, associated diabetes, hyperlipidemias, primary open angle glaucomas, and all other conditions mentioned in the predisposing factors as we have discussed earlier, and smoking should be avoided. Now, the observation and monitoring is all that is required in the patients with a mild to moderate visual loss. Like visual acuity is better than 6/18, we can just go with the observation and monitoring, as the condition, especially the non-ischemic CRVO, is more than the 50% cases of the CRVO resolves with almost normal vision. Next is treatment for the macular edema and retinal neovascularization is that we have to go with the macular edema and retinal neovascularization. We can go with the medical therapy, in that we can give it the intravitreal injections of the anti-VGFs, which includes bevacizumab and ranibizumab. And basically these are useful for associated that is basically associated with the macular edema and associated with the neovascularization, and this has to be repeated every 1 to 2 months. Now we can give the intravitreal triamcinolone may be given for associated macular edema. Repeated injection may be required, and intravitreal dexamethasone. Corticosteroid slow release implants may be used as alternative to triamcinolone, which needs to be repeated every 2 months. Effects of the Ozurdex last for about 3 to 6 months. Now that's just. Now we can go with the laser therapy, which is not a grid laser. Like there is a specific point, like this is a fundus and you are going with a grid laser. So grid laser is like in the specific part. So grid laser is not recommended for macular edema in CRVO. However, persistent CME, that is the macular edema in BRVO, may be treated by the grid laser. Next, we have the pan-retinal, like whole of the retina has to be coagulation. Pan-retinal photocoagulation is generally not recommended as prophylaxis, even in the cases with the marked ischemia, except in the patients not likely to compel with regular follow-up. PRP should be performed without delay in the CRVO when neovascularization neovascularization dwells anywhere. So PRP is indicated when there is neovascularization which dwells anywhere in the angle, in the iris, in the retina, which can be periphery or which can be a disc. PRP involves the application of about 1500 to 3000 burns, which is spaced one burn width apart using the frequency doubling YAG laser or the argon green laser. We can go with the scatter laser photocoagulation is recommended for neovascularization elsewhere in the patient with BRVO. Surgical therapy, basically we'll discuss about the surgical therapy, may be required in the form of pars plana virectomy for treating the following complication associated with the venous occlusions. We can have persistent vitreous hemorrhages, we have tractional type of the retinal detachments, we can have the epiretinal membrane, we can have the intractable neovascular glaucoma. For that we can go with the surgical therapy. And PPV, that is a we have the PPV that we are going to discuss about is that is pars plana virectomy, should be combined with the endolaser pan-retinal photocoagulation when required, and we can have some pars plana placement of the glaucoma drainage devices may also be required in the patient with the neovascular glaucoma. And we can have the radial optic neurotomy, which once proposed but to surgically decompress the CRV, that is central retinal vein, at the level of the scleral outlet that has not proved useful. So this was about, just you have to understand that whenever we are going to discuss about this condition, you have to understand there is the retinal venous occlusion about some of the important predisposing factors, and these are the ones which are usually affecting the people of the 6 to 7 decades of the life. The pathogenesis is simple, like there is a pressure on the vein by the erythrosclerotic retinal artery. Why? Because they share a common adventitious sheath, and we can have the central one and we can have branched one, and difference, one causes mild visual loss and one causes sudden loss. There is RAPD present, there is changes in the ERG that is going to be there. And this was about what the various funding examinations and what are the various funding signs and how you are going to investigate it, how you are going to manage it. So this was about medical therapies given usually when you will see any new, we can see there is macular edema, cystoid macular edema, there is neovascularization. So we have to go with the medical therapy, and we can go with the laser therapy also, which is there. So it was about one of the important vascular disorders of the retina, of the retinal vein occlusion. In the next video we'll start with the central retinal artery occlusion. Okay, bye bye.